But since we speak English, we should just speak English. So we've got a few hearts, but I wrote on the board there next to Pellick's Murmur Talk, which is one of my favorites of all time, the questions that are the most, I think, important to answer. So if you're reading echoes that day, or you're on cardiology service, or whatever it might be, and you're presenting to the surgeons, really, I think the big things they need to know are, how is a truncal valve, right? How many leaflets? Is it leaky? Is it stenotic? Does it look dysplastic, right? The thick and rolled edges that everybody likes to talk about in echo. How do the pulmonary arteries arise from the trunk? Obviously, the Collette and Edwards classifications that everybody likes to use or just describe it, because there are some shortcomings with Collette and Edwards, like type 4, which is essentially pulmonary atresia with VSD and MAPGAs. Then, how do the coronaries arise from the common trunk? Where do they come off from? Is it a single coronary, which can happen sometimes? And then, is it a pulmonary aortic dominant common arterial trunk? And this is a very Andersonian notion, and we use this. Basically, if the arch is interrupted, severely hypoplastic or coarctation, then it's a pulmonary dominant for us. If the arch is fine, then it's aortic dominant, based on blood flow, essentially. And then the border of the VSD. The VSD is usually always going to be an outlet type VSD, but the posterior-inferior border of these can either be fibrous with tricuspid valve tissue, or it can be muscular with muscle. And that can be significant because depending on how far down this VSD comes, it can be closer or further away from the AV node. So if it's got a muscular posterior-inferior border, the surgeon has a little more wiggle room with where they threw their sutures. All right, so this is a heart, would have sat in the chest like this, anterior surface towards the screen, left over here, right over here, head superior up here, legs inferior down here. All right, so we'll do what we normally do, which is find the right atrial appendage externally, which is this triangular, broad-based, pyramidal-looking thing. We'll open it up. And when we open it up, you can see that there's pectinate muscles that spill outside the confines of the appendage. So that's consistent with a morphologic right atrial appendage and right atrium. And then here is the oval fossa. You can see it's more or less intact. There really isn't an oval fossa ASD. And this one is actually pretty circular. And then here is the coronary sinus, the little slit right there. And then here would be the tendon of Totaro. And so the coronary sinus, the tendon of Totaro, and then the septal leaflet of the right AV valve here would then form the triangle of Koch. So coronary sinus, tendon of Totaro, right AV valve. So about here, at the apex of that triangle, is where we'd expect the AV node to sit. And then we come to our first atrioventricular valve, which does seem to have 3 leaflets. There's one here, there's another one here, and one here. And you can see there are septal connections of this valve, so all consistent with a morphologic tricuspid valve. The ventricle has coarse trabeculations. There is a septomarginal trabeculation here, so consistent with the morphologic right ventricle. And then here is the cranial limb of the septomarginal trabeculation. Here's the caudal limb of the septomarginal trabeculation. So the Y of the septal band, and in the middle of this Y is VSD, right? And remember, this is what defines an outlet VSD, is that it lives within the Y of the septal band between the cranial and the caudal limbs of the septomarginal trabeculation, all right? So it's kind of snuck in there. And then when we get to the outflow tract, it already looks different, right? First of all, here are the valve leaflets here. And you can see that they're fairly dysplastic looking, right? Here's what people are describing as rolled edges. You can see that the edges here are not nice and just kind of straight across. These are also pretty thickened. Like, look at the the tricuspid valve here and how thick these leaflets are versus this, right? And if you quantify this, there's one leaflet here, a second leaflet here, a third leaflet here, and it looks like there's this fourth leaflet, but this actually connects back to this. That's just transected. So this is a 3 leaflet, 3 sinus truncal valve that's pretty dysplastic. Okay. Yeah.
Is there ever a case where, like, leaflets in sinuses usually go to, like, would there ever be a valve that has, like, a mismatch in those numbers?
Can be. It can. Just like with the aortic valve, that can happen too, because you can have an incomplete raphe. But, yeah, it's infrequent, but it can happen. And then you see this big thing coming off here. So that's going to be the main pulmonary trunk, which from the outside is right here. And then you can see here's the right pulmonary artery, and here's the left pulmonary artery coming off of that, right? So the pulmonary arteries in this case arise from a common pulmonary trunk, and then the branch PAs come off of that, all right? So if you were to use Collette and Edwards, that would be the type 1. Right. And then the coronary arteries are in here too, and you can see one of the orifices is back here in this sinus, and it'll be a little easier to see when you get up here. And so by definition, a common arterial trunk has to be a single arterial exit from the heart, which gives rise to the coronaries, the ascending aorta, and the pulmonary arteries. And so here's the ascending aorta then. Here's a transverse arch, and then the descending aorta here. Okay. And the only thing that common arterial trunk can really get confused with is pulmonary atresia VSD and Collette and Edwards and the Van Prague system, both of, I think it's A4 and the Van Prague, and it's 4 in Collette and Edwards. They have extrapericardial pulmonary arteries, which makes that pulmonary atresia VSD. All right, because common arterial trunk, if the PAs are coming off the trunk, the common part of the trunk, they should be intrapericardial in their origin, and then the branched pulmonary arteries become extrapericardial. Right, so that's the shortcoming of Collette and Edwards, which is a system that we usually use, and it's totally fine just to understand that. Once you get to that point, there is some overlap with pulmonary atresia VSD, so just make sure you're thoughtful about that. Then if we flip this over, smooth-walled atrium, all the pectinate muscles are confined within this appendage here, which is externally looks like a left atrial appendage. Once again, there's no ASD that you can see from this side either. This is all consistent with the morphologic left atrium. And then here's a left-sided AV valve. Seems to have 2 leaflets. Here's an anterior leaflet. Here's a posterior leaflet. And there are no connections to the septum here of this valve, so consistent with the morphologic mitral valve. The ventricle here has fine crisscross trabeculation, so consistent with the morphologic left ventricle. And then here's the outlet of that left ventricle, and you can see the only outlet is through this VSD. And you can see this valve leaflet tissue here, prolapsing.
Is that relatively small, or do you think it's like a good size?
It's a good size. Yeah, it's actually, I think by echo, we expect them to be a lot larger sometimes. But this is actually pretty good size for a VSD. So that's common arterial trunk that we would describe as being aortic dominant with PAs that arise from a common trunk.
That makes it.
A pulmonary trunk that arises from a common trunk. A Collette and Edwards type 1.
Mm-hmm.
So then here's a second heart, which would have sat in the chest like this. Right, so anterior surface towards us, left over here, right over here, superior head up here, and here's the trachea, and then inferior legs down here. And then posterior surface towards the towels. So here's an appendage that looks triangular, pyramidal, or broad shaped, so we'll assume this is going to be the right atrial appendage. So we'll start there. And when you open it up, you've got pectinate muscles that spill outside the confines of that appendage, consistent with a morphologic right atrium. And then we do find the oval fossa here, and you can see there are defects in the oval fossa. So there is an oval fossa ASD right here. And then here is the coronary sinus. Here is the tendon of Todaro. Here's a septal leaflet of the right AV valve. So this triangle here is the triangle of Koch, and at its apex would live the AV node. Okay. Then we get to the right atrioventricular valve here, and it does appear to have 3 leaflets. And there are septal connections, so consistent with the morphologic tricuspid valve. The ventricle it leads into definitely has coarse trabeculations, and there is a septomarginal trabeculation here, so consistent with the morphologic right ventricle. And then when we look at the septomarginal trabeculation, here's its cranial limb, here's its caudal limb, and then in the Y of the septal band is VSD. Okay, so that's going to be an outlet VSD. And I do think by echo, you are sometimes able to find the cranial and the caudal limbs of the septomarginal trabeculation. And sometimes it's just eye of the beholder, so if you know you're looking for it and you're being diligent about it, you can see it. So I do think echocardiographically you can define this, and certainly with advanced imaging you can. And then we get into some sort of an outflow tract here. But right off the bat, you see a coronary artery that's coming off of it. And then you see this left pulmonary artery that's coming off of it. And then back here is the ascending aorta, which also appears to be coming off of this trunk. So a common arterial trunk, because the ascending aorta comes off of it. The coronary circulation's coming off of it, and the pulmonary arteries are arising from it. So then this becomes a truncal valve here. And it's not as thickened as the last one we saw, but it is still a little thickened. And you can see that there's some redundant tissue on these edges. They're still not like nicely defined at their borders. So dysplastic valve for sure. And this has 1, 2, 3, 4 leaflets. So this is a 4-leaflet common arterial trunk. There are 4 sinuses. Yeah. This is the first one, the second one, third one, and here's the 4th one.
And there are 4 sinuses?
Mm-hmm.
And when you say sinus, do you mean that there's coronary flow coming from each of those sinuses, or just
No.
that there's like a potential space?
Correct. There's a space. Yep. Just like, remember in the aortic valve, there's 2 coronaries that arise from it, but 3 sinuses, right? And you can have variations in that too, obviously. And then there's something else coming off of this trunk here. But here is the LPA. The RPA comes off back here. Okay, so here's the RPA externally, and that comes off through an orifice back here. And we have the ascending aorta right here. So any guesses as to what this might be?
It's very small, so that, can we say that they're pulmonary dominant?
This is pulmonary dominance, yes,
But-
absolutely. And so if you have pulmonary dominance, what could this extra thing coming off the common trunk potentially be? It's an arterial duct, right? What we normally don't associate with common arterial trunk, right? Which we say there usually isn't a duct. But in this case, the ascending aorta is of good size, and then look what happens at the transverse arch here. It becomes really, really hypoplastic, right? So it's not interrupted, but there's significant transverse arch hypoplasia, so there is a duct, which is this guy right here. And it's just been transected, but you can actually put it together because here is the aortic end of the duct, and so things would have come together somewhat like this. Sorry, can't see it. So this is actually an arterial duct. So this common arterial trunk is giving off coronaries. So here's one of the coronaries here. Here's the other coronary right here, and you'll be able to better see it when you get up here. The branch pulmonary arteries, here's the LPA, and then the RPA comes off back here. Okay? And then the ascending aorta, which its orifice is right here. And that's right up there. Okay?
And I anticipate you are naturally not a huge fan of the distinction here, but between type 2 and type 3, those PAs would be considered coming off from different sites.
So remember, in all the classifications, once you get to an interrupted arch or severely significantly hypoplastic transverse arch, that becomes a category on its own.
Got it.
And I think it's hard to know what to make of these, right?
Yeah.
Because is the common trunk extending up here, and then these are just separate orifices, or is this from this part here, because the ascending aorta level is right here, like is this segment from here to here then a pulmonary trunk that then gives rise to the branch PAs? So it's hard to
And
know
I guess
how to describe
my
that.
bigger question is, and I feel like it might be easier to understand in this setting, is the distinction between this like kind of type 2 and type 3 and the surgical approach. Let's say if those PAs were slightly farther apart, how does that, why is that distinction necessary?
I don't think it really is.
Yeah.
Correct. And we have some that are going to have separate orifices.
Yeah.
But yeah, honestly, if they're right by each other or they're further apart,
You can just describe it that way.
that's correct.
And that little ductus, again, it's not like any, like neither of the PAs nor the aorta is coming off of it or any, you know what I mean? Like, because I've had aortic fetals or sometimes the NICU laughs, like, oh, is this like a ductal dependent lesion? And again, I never think of these as such because usually there's not a duct. But even if this duct involutes, it's not gonna like take something with it.
I think it wouldn't take anything with it, but I think this would become a problem. So this duct is about the size of the ascending aorta. And then look at the transverse arch here.
So then maybe they could be ductal versus systemic one.
That's correct. That's correct.
I feel like you can't always see a duct. I mean,
Correct.
it's pretty rare, right?
Correct. It's super rare.
Okay.
It's only in these pulmonary dominant ones where there's significant hypoplasia of the aorta, there's significant coarctation, or there's interruption. Yes, we usually don't see this. So if we flip this over, here's another atrium, smooth walled. Here is the left atrial appendage here. All the pectinate muscles are inside. So a morphologic left atrium. Then we find a left atrioventricular valve here with two leaflets. Here's one here, and no connections to the septum with that valve, so a morphologic mitral valve. And then this ventricle has fine crisscross trabeculations consistent with the morphologic left ventricle. And then the egress of this ventricle is entirely through this VSD right here. Right. And the common arterial trunk can have variability, and if it sits entirely over the right ventricle, has override and sits above both ventricles, and in some cases can entirely kind of commit itself to the left ventricle. In this case, this is almost exclusively from the right ventricle. And that seems to have some clinical implications in some subsets of common arterial trunk. So we do have examples of common arterial trunk with an intact ventricular septum. And in that, there's 3 distinct phenotypes. Like, we did a cluster analysis. And what ends up coming out as being significant and affecting clinical outcomes too is how the trunk is kind of related to the ventricles. So here's another heart, would have roughly sat in the chest like this, anterior surface here, superior head up here, inferior legs down here, left over here, right over here. This looks like a pyramidal, triangular, broad-based appendage, so we'll open it up here. And then you see pectinate muscles that spill outside the confines of the appendage, so consistent with the morphologic right atrium. You can't miss this oval fossa, at least I hope you didn't. And you can see there's a good size defect there, so there is an oval fossa ASD. And I want you to appreciate how usually the margins of the oval fossa are pretty well defined, right? Like we can't obviously see this by echo, but like this truly is a distinct structure. And then here is the coronary sinus, back here. Right, so coronary sinus, tendon of Totaro, septal leaflet of the right-sided AV valve. Draw our triangle of Koch here. We would expect the AV node to sit here. We come over to this right-sided AV valve. It definitely has septal connections, and it appears to have 1, 2, 3 leaflets. The ventricle it leads into seems to have coarse trabeculations. There is a septomarginal trabeculation here, so all consistent with the morphologic right ventricle. And then when we follow the septomarginal trabeculation up, here's the cranial limb, and here's the caudal limb, and here is a VSD. You can see this VSD looks a little relatively smaller than the other one, but an outlet VSD, and I failed to mention in the last ones, all the borders so far, the posterior-inferior borders here have been muscular, right? So a muscular posterior-inferior border. Sometimes the tricuspid valve, which is not too far, ends up forming the border, and it's a fibrous border at the posterior-inferior margin of that VSD. And then if we flip back over here, remember, we're going to say the AV node was somewhere here, based on the triangle of Koch. Now if you flip this over, you're not all that far from that VSD, right? So here's where we think the AV node is. Flip it over. So you're talking about somewhere behind this is where the AV node is. So if you don't have this muscular bar here, your surgeons have to be extra careful about how they're throwing sutures at this border, which they should be regardless, and they usually are awesome at it. But if you have a fibrous border here, you can see how the risk for heart block, even if it's transient, can certainly go up. Okay. Then when we look at this outflow, this valve looks pretty bad. Like, it's just like little nubbins of tissue. And you can see it's just like, obviously just not very well defined, rolled edges, certainly thickened. So look at these valve leaflets compared to the tricuspid valve leaflets, right? Just markedly different. There's also this thing here, which looks like it's a coronary artery arising from it. So it looks like we're dealing with a common arterial trunk, because here's the ascending aorta then. Here's the coronary artery, and then there are two holes right here, which seem to be the orifices of the left and the right pulmonary artery. You can see the right pulmonary artery orifice is like this little slit compared to the LPA, okay? Now, is there a little part that's kind of like a common pulmonary trunk first and then it splits? Because I can make that argument here that maybe, and it's like 0.5 millimeter of common.
Type 1.5.
So this actually exists in the literature, and people have described hearts like this, but it's like, what's the use? Just tell it what it is. But I think it does matter, because let's say you think this is a small segment of common pulmonary trunk here. To expect our surgeons to be able to mobilize this like this is a common pulmonary trunk is very difficult. Yeah. Right? And this is most likely going to require, them mobilizing these branch pulmonary arteries separately and then putting a conduit. So I do think there are implications, at least in this setting. Whether or not, they're right next to each other or they have some distance to them, maybe that's not the most important thing.
If it's that close, then it's
correct.
for all intents and purposes a type.
Correct. So people have described the alleged 1.5, which it's like, why don't we just describe what's actually happening in words, and that way we don't have to confuse each other. And at 3 a.m. you wake up and you forget what Colette Edwards was actually, and then have to Google it. It's like, just describe it.
And then in terms of describing the valve, I imagine the most important thing is just the gradient across it and stenosis, rather than the structure itself. Like what's important about the quality?
I think it
of the
all
leaflets?
is.
Yeah.
I think so. This looks to have 3 leaflets.
Yeah.
It's hard to even define what a sinus here is, right?
Uh-huh.
Like it's probably got 3 sinuses, and it looks like a single solitary coronary artery. But like, I think functionally, what the valve is doing is going to be what's more prognostically helpful,
Yeah.
right? And it's not particularly surprising that a valve like this shows up in our collection,
Yeah.
right? Because obviously it seems like this kid would have done clinically worse, unfortunately. I would describe it all.
Yeah.
When we've looked at common arterial trunk and done cluster analysis to see how things fall and segregate out naturally, the morphology of the truncal valve does seem to be an important factor. But that's just based on anatomic findings. That wasn't really bringing in clinical factors.
And those structures have implications in terms of how regurgitant
Yeah,
are, if they need to repair that in addition to.
correct. And then obviously a truncal valve that's not competent can be the gift that keeps giving, and unfortunately not in a good way. It's the thing most of us have experienced. If we flip the heart over, here's a smooth-walled atrium. You can see my glove is poking through the oval fossa ASD. Here is the left atrial appendage, and this one is transected kind of nicely, so you can see how all the pectinate muscles are here, and they stay within the confines of the appendage. And this is where the mouth of the orifice of the appendage is to the left atrium. And then here is the mitral valve, anterior posterior leaflet. So it's a 2-leaflet left AV valve with no connections to the septum, so a morphologic mitral valve. This ventricle's got fine crisscross trabeculation, so consistent with the morphologic left ventricle. And then if you look down the left ventricular outflow tract, you can see the only egress is through this VSD, and there you can see the leaflets of the truncal valve as
All
well.
of these so far, the common arterial trunk has been more like overriding the right limb.
That's right. Yeah,
But that, again, that doesn't determine dominance.
correct. Correct. And you won't hear people talk about dominance a lot here. The Europeans tend to use the Andersonian way more. It just is what it is, so just be familiar with everything. And if you ever forget any of the systems, just describe it and you'll be good. Right, so here's another heart. This one's a little bigger. Would have sat in the chest like this. Anterior surface, head superior up here, legs inferior down here, left, right. Here's a nice big triangular broad-based pyramidal appendage, so we'll open this up. And as expected, there's pectinate muscles that spill outside the confines of the appendage, so consistent with a morphologic right atrium. And remember, especially in hearts that have been operated on or have abnormal atrial pressures, external morphology and external appearance of an appendage might not actually be consistent with what the actual morphology of the appendage is. So that's why I always say it looks like it's externally a right atrial appendage, but there's certainly hearts where that doesn't jive with what's on the inside. So just because the outside looks like it doesn't mean the inside does. Here's the oval fossa. Looks pretty intact. And here is the coronary sinus back here. So when we look at this, it would end up being coronary sinus, tendon of Totaro, right-sided AV valve, and everything's kind of chopped up here. I don't know what happened. So we would expect the AV node to sit roughly here. There is a right-sided AV valve that appears to have 3 leaflets, although everything is kind of chopped up here. There are septal connections, so consistent with the morphologic tricuspid valve. The ventricle it leads into has coarse trabeculations. There is a septomarginal trabeculation here, so consistent with a morphologic right ventricle.
That was too fresh.
And then you can see within the Y of the septal band that there is a AVSD. Okay. And the reason I brought this heart, even though it's kind of falling apart, is because you can actually see the valve leaflets kind of nicely here. All right, and you can see how they are kind of thickened. The edges aren't as well defined. You can see what I think people describe as rolled by echo. So you compare this to tricuspid valve tissue, which is right down here, and you can see how it's markedly different. Like, you can tell more distinct edges here than you really can here. Right. Unfortunately, I don't know why this heart has been as destroyed as it has. It's hard to tell where the branch PAs come off, but I just wanted to share this heart because of the leaflets, and it's a little easier to appreciate the leaflets. Looks like 1, 2, 3, and a 4th is transected here. So this looks like a 4 leaflet, 4 sinus truncal valve. Then if we flip it over, smooth-walled atrium. Once again, we don't appreciate an atrial septal defect. Here's a left, what appears to be a left atrial appendage. When you look inside it, there's pectinate muscles, and they're all confined within the appendage itself. So all consistent with the morphologic left atrium. There's a left AV valve here that doesn't have any connections to the ventricular septum. Consistent with a morphologic mitral valve, so anterior, posterior leaflets. Find crisscross trabeculations in this ventricle consistent with a morphologic left ventricle. And here you can see that when you get off the out the left ventricular outflow tract, you end up right into the common trunk. So if the septum would have sat like this seems committed to both. Right, so unlike the ones we've seen so far, so that was a timely comment. Right. And then the last heart should have sat in the chest like this, roughly. The trachea is here as well. So anterior surface out, posterior surface towards the towel, head and neck up here, legs down here, left over here, right over here. Triangular, broad-based, pyramidal appearing appendage, so we'll open it up there. There's pectinate muscles that spill outside the confines of the appendage, so consistent with the morphologic right atrium. And here you can see the oval fossa, and it does look like there's a defect right here. Okay, I can put the probe through there. So, an oval fossa ASD.
Yeah, all those are secondary defects.
That's correct. That's correct. The secondary septum is the only true atrial septum. Remember, there isn't actually a primary septum, and I don't know if Moss and Adams has updated their book, but the Anderson book has been updated for years. We've demonstrated this very nicely with episcopic microscopy, and a lot of the embryologic textbooks are now more accurate. So the primary septum is the true atrial septum. The secondary septum is just a fold. Okay, and that's why when you do a septostomy in the cath lab, if you end up poking out too superiorly that is not a septum there, it's a fold, you will leave the heart and cause a pericardial effusion. So, can't really tell you where the coronary sinus is in this heart. Some hearts don't have one. I don't know if that's the case or I just can't see it. Could be either one, I'm getting old. Here's a right-sided AV valve, appears to have 3 leaflets. It has septal connections, so consistent with a morphologic tricuspid valve. This ventricle has coarse trabeculations. There's a septomarginal trabeculation. Here's the Y of the septal band. Here's the cranial limb of the septomarginal trabeculation, the caudal limb. And here's a VSD. You can see how close this tricuspid valve tissue gets to the posterior-inferior border, but this still is a muscular posterior-inferior border. So even though we can't see all of our landmarks, let's assume that maybe the AV node would live here. You can see right on the other side of this, you can see how close it can get to the rim of that VSD, which is why the location and the borders of the VSD are important, because the clinical implication is the likelihood of heart block. Then we get out into this outflow tract here, and right away you see that this does not appear to be a normal pulmonary trunk. You see coronary arteries right here and right here. You see 2 holes on the posterior aspect here, which are going to be pulmonary arteries. So this is going to be the LPA here, and this is going to be the RPA here. And then this obviously then is a common, this is a truncal valve here. And let's see, looks like 1 leaflet, 2 leaflets, 3, 4 leaflets, 4 sinuses.
And can you talk about like rapid versus commissure?
One day we shall.
Okay.
We'll do it with the aortic valve. It'll be a little easier with the aortic valve. And we can do that next time. And then here are the branch PAs. Now, I don't know what distance makes it a type 2 versus a type 3. I have the beholder, right? These are pretty close to each other.
Mm-hmm.
I think it would be safe to call this a type 2. Mm-hmm. Right? But you can see how, like, type 2, type 3, certainly a spectrum. And so you could just describe this and say, look, the branch PAs come off the posterior leftward aspect of the common trunk, and the orifices are pretty close to each other, right? Like, and that would describe this very well.
Mm-hmm.
And plus, we're sitting there when we're describing it and showing the surgeons the images as well, which is also helpful. And so here's the left pulmonary artery right back here. Externally, here's the right pulmonary artery here. Here's the trachea, obviously. And then the ascending aorta and the transverse arch and the descending aorta here. Okay.
Is that the trachea?
The trachea is right back here, yeah. Yeah, so when you're intubating, you are putting a tube right into there. So there's the epiglottis, right? We get our blade back there, pull us forward, and you put the tube right down there.
Oh, can we make a vascular ring? Can you see it from the top if it were to? Okay, it would go behind.
So if you had a vascular ring, let's say you had a right arch, so it would course over here, right, and the descending aorta would come downwards, then you would have something that would course around this way. And we could do vascular rings one day too. We have some really good examples of vascular rings. Yeah, yeah. So it's up to you. Aorta, aortic valve next time, or vascular ring next time.
I'm for vascular ring. Yeah.
All right, vascular ring it is. And then if you flip this one over, just for completeness sake, here's an atrium with a smooth vestibule. No pectinate muscles that spill outside the confines of this appendage right here, so consistent with the morphologic left atrium. Here's a left-sided AV valve with 2 leaflets here and no septal connections, so consistent with a morphologic mitral valve. Here's a ventricle with, I don't know, it's hard to call these trabeculations anything, but they're not as coarse as these. And then the only egress from this left ventricle is through this VSD. All right, so another common arterial trunk that's really more committed over to the right ventricle. But this one's nice because you really see the coronaries very nicely here, and you see the branch PAs come off very nicely. There are some variants of common arterial trunk. There's common arterial trunk with intact ventricular septum. And we've got a paper coming out describing that nicely. And then we've got an example of a common arterial trunk with pulmonary atresia as well, where there is a strand that comes back. There's a common pulmonary trunk that comes back to the common trunk. The valve's just not existent. It's just closed. So we do believe those can exist together. Questions?